Hello, and welcome to our evening presentation for current and future clinical trials to treat Alzheimer's disease. I'm Melissa Long, the Director of Education and Support, and we have Dr. Henry Tran with us. Our mission here at Insight is to provide specialized care, support, and education for all individuals in all stages of memory or cognitive impairment, their partners, and the community. Our vision, a community where those living with memory or cognitive impairment and their care partners can achieve the highest quality of life. We're a leader in dementia care in Northern Virginia, and Insight is a nonprofit. We started 41 years ago in 1984 to help families on their journey. We provide care that is specialized with adult day programs for people in all stages, from MCI to hospice. We connect and build relationships and support care partners on this journey, and with our creativity, dementia experts sharing their knowledge and resources, because every journey of dementia is unique. I would like to introduce our speaker, Dr. Henry Tran, and my computer's not cooperating with me. I apologize. See if it will work. All right, so he's a certified cardiologist and assistant professor of medical education. He has over 20 years of experience in medicine. He's the CEO of SANA Research, which is an independent clinical trial site dedicated to neurological and cardiovascular disease trials. He's a fellow of the American College of Cardiology and the American College of Physicians. He has received awards for his teaching and been recognized as a top doc by Washington's Magazine. He's committed to community service and humanitarian work. He has volunteered on several medical missions in Vietnam throughout the Tran Teen Foundation. He is also currently serves on the board here right at Insight. He grew up in McLean, Virginia. He majored in history at the University of Virginia and received his medical degree from Georgetown University. He completed his internal medicine residency and cardiovascular disease fellowship at NYU. And in his spare time, because he has some, he enjoys playing tennis, cooking, and running after his toddler. So welcome and thank you for being here. I will stop sharing my screen and you can go ahead and share yours. We do have a Q&A box for housekeeping stuff. If any of you have questions throughout this presentation, please put them in there. Dr. Tran, would you like me to ask the questions at the end or as they pop up?
As they pop up, I think that's kind of better. Okay. Yeah.
Great. And for those of you on, we are recording this. It will be posted probably within the next week. So go ahead.
Great. Well, it's a great honor and pleasure to be here speaking to y'all. I thank Melissa for the invitation. You know, I'm a proud board member of Insight. I really believe in what we do every day and the mission, and you know, educating people to understand this horrible disease is very important. So my goal tonight is to give everyone a broad and decent overview of where current research is in Alzheimer's disease. I'm hopeful for the future because I think we're on the precipice of making some major advances in treating this disease. So I hope to give you some hope, some details, and you know, maybe use this as a launching pad for a good discussion. So as Melissa said, I am a clinical trial researcher. Therefore, we do receive research support to enroll people in for multi-center studies. So these are some of my disclosures. So the goals for tonight is to, again, give you the kind of current state of where Alzheimer's disease research is at. I'll highlight some of the very impressive advances in biomarkers in terms of early detection and trial design. And then we'll also talk a lot about, you know, the new treatments of Alzheimer's. Hopefully some of you have already heard about the anti-amyloid antibodies, such as lecanemab or donanemab, and we can talk about some of the pros and cons of that. I'll touch a little bit upon some of the challenges we face every day enrolling people for clinical trials, and especially enrolling a diverse population in trials that reflects, you know, the general population as well. So just some history, because I was a history major, as Melissa mentioned. Dr. Alzheimer was the one who really made the first microscopic descriptions of what we now know as Alzheimer's disease. So back in the late 19th century, people who had dementia were thought to just have developed it due to old age, and we really didn't understand the pathological basis of why or what occurs in the brain. And so in 1901, Dr. Alzheimer was rotating through an asylum in Germany, and he encountered what I would consider a relatively young patient, only age 51, who was experiencing a lot of strange symptoms, and most notable for very poor short-term memory. Well, that patient died about 5 years later, and Dr. Alzheimer was able to perform an autopsy. And around this time, microscopy was exploding, and pathology was identifying new stains to identify different cell types. So we were identifying muscle cells and heart cells and brain cells, and some of these stains were able to identify unique features of a patient with Alzheimer's disease, and that is notably amyloid plaque, which is like a starchy accumulation that occurs outside brain cells, and something that occurs inside called neurofibrillary tangles, or NFTs. And I'll discuss both amyloid and tangles in much more detail. So if you think about it, Alzheimer's disease probably existed since, humans were able to survive into advanced age, but it's really only been about 120 years that we were able to really identify it, at least on autopsy. A lot of people ask me or get confused by Alzheimer's and dementia, and they think it's interchangeable. And I just, again, want to review that dementia is an umbrella term that really describes a group of diseases that are all hallmarked by problems with cognition, thinking, judgment, and memory loss. And though Alzheimer's is the most common and most prevalent, especially in people over age of 65, there are definitely other types of dementia that must always be excluded or evaluated when we see a patient with a new diagnosis of dementia. And we want to make sure there's no vascular dementia, which is basically dementia due to strokes or infarctions of the brain. Sometimes people, for instance, with atrial fibrillation, they're not treated well with anticoagulation, and they come in with several strokes that we find on head imaging. Many people may know that Bruce Willis, the actor, has frontal temporal dementia. That's about 10% of the cases, and that's really marked by deterioration in the front part of the brain. A lot of these patients lose their language skills, and they almost become mute. Lewy body dementia is less prevalent than that. This is a type of dementia that's also associated with movement disorders such as Parkinsonism. Lewy body dementia unfortunately affected Robin Williams. Lewy body dementia tends to be more aggressive than Alzheimer's. It has these characteristic symptoms of sleep cycle disturbances, visual hallucinations, and varying levels of alertness. Like some of these patients may end up just being very sleepy for days on end, and then have other periods of being more alert. So again, dementia is a very broad term, but for today's talk, I'm really going to focus on current state of treatments for Alzheimer's. So how many people have Alzheimer's? It's estimated that maybe 10% of everyone over the age of 65 has it, and it tends to affect women a little bit more than men. And as you see, especially in America, as the baby boomer generation does age, so will the prevalence of Alzheimer's dementia grow in America. So it's really going to be a huge public health emergency. I mean, I would say, dementia doesn't just affect one person, it really affects the entire family. And it takes an immense amount of caregiver resources and attention to take care of one person. So in 10, 15, 20 years, this is going to be a serious burden on society and our healthcare system and our caregiver system to how to adequately take care of all these folks. Many of you know the symptoms, but the symptoms are more than just memory loss. Patients lose language skills, they become disoriented easily, they lose episodic memory. For instance, they may be looking for something, and then after opening 2 or 3 cupboards or walking into a different room, they may forget what they were looking for to begin with. As the disease progresses, unfortunately, mood instability increases, and patients can have varying levels of aggression or anxiety or agitation. And there has been some research into how to better treat these later stages of complications due to Alzheimer's. And another thing is, what causes Alzheimer's? The majority of Alzheimer's is late onset sporadic, which occurs after age 65. And we estimate about 70% of that is inherited, though we really don't have all the genes worked out yet. One of the major genes that we do know that increases the risk of Alzheimer's in late stage is ApoE, specifically the E4 mutation. So ApoE is a gene that you would inherit, one from your father, one from your mother. And if you get the bad E4 copy from both parents and you're what we call an E44, that person has a 17 times risk of developing Alzheimer's compared to the general population. So, ApoE44s are unfortunately a very bad diagnosis. But beyond the genetic risk factors, there are things that have occurred either acquired in life or lifestyle that do increase the risk, such as head injuries, such as people who box or engage in concussions due to football. Clinical depression increases your risk of Alzheimer's. And from a heart standpoint or cardiovascular standpoint, having high blood pressure that's not well controlled, or having heart failure, for example, also increases your risk. We'll just skip ahead here. So, there are various ways to diagnose Alzheimer's dementia, and I will say the traditional methodology really has been, taking a history from the patient, a physical exam, and then cognitive testing. Sometimes patients will undergo, a 3 or 4 hour neurocognitive assessment by a neuropsychologist that really delves deeply into various aspects of someone's cognition. But recently we had made more advances, both on imaging and with blood testing. So some of you may be aware of a technology called PET scanning, where we inject radioactive isotopes into the body that can bind certain things. So for instance, you have cancer, there are isotopes that are attracted to cancer cells. So we can locate tumors on a PET scan based that way. Using similar, theory, we have been able to tag nuclear tracers that are sensitive to amyloid or sensitive to another bad protein in the brain called tau, which earlier mentioned can create those neurofibrillary tangles. So PET imaging has become, in the last few years, another very important diagnostic tool to actually identifying Alzheimer's. But what is more revolutionary than that, I think, will be blood testing, which is biomarkers. So the ability to take someone's blood and test that blood for abnormal proteins such as amyloid or tau. I think that's going to really revolutionize the diagnosis of Alzheimer's, and more importantly, make the diagnosis of Alzheimer's earlier, even before someone's symptomatic. And I think by intervening at these earlier stages, we're going to be able to preserve cognition, preserve brain function, because as of yet, we really haven't developed anything that can grow new brain cells or reverse dementia. So I'll talk a little bit more about biomarkers. We'll skip over that. So I've talked about these two proteins, but I really want to hammer this point. And one of the major things I want you to walk away from this lecture is understanding when someone says amyloid and tau, what that means. So if you see the panel on the right side of the screen, the normal panel shows kind of what a microscope would look like. Looking at the brain cells, those are called neurons, and all the yellow stuff in between neurons is what we consider the extracellular space. This is like support tissue to support the brain. What you see in an Alzheimer's brain, what Dr. Alzheimer saw in 1906, was when you stain these brains, you see two hallmark signs. One is amyloid plaque. These are plaques, starch-like accumulations that occur outside the neurons, outside the brain cells. And these are aggregates of abnormal proteins that fold into these sheets, basically. And so we call these beta amyloid sheets. And if you look inside the neuron itself, you'll see these kind of pyramidal, polygon shapes inside the neurons, and these are called the neurofibrillary tangles, or known as NFTs. And if you take out the tangles and you look to see what's inside, they're comprised of abnormal tau proteins. Okay, so again, amyloid is an abnormal protein that accumulates outside the brain cell, and then tau is an abnormal protein that accumulates inside the neuron. And these are the two hallmark features that we see in patients with amyloid. No, with Alzheimer's. And as I said, with the PET technology, you can tag a tracer that's specific to amyloid and inject it into a patient and then image the brain. And if you see that tracer absorbed in certain parts of the brain, that's a diagnosis of Alzheimer's. So at the top is a normal brain on the PET scan, and on the bottom is a positive scan, and you see those abnormal areas of red and yellow. Those are amyloid accumulations in the brain and occurring in the front part of the brain and the sides, and those are two of the hallmark areas of where Alzheimer's first starts. So this is a positive PET scan for amyloid. Similarly, we can tag for tau proteins with PET technology as well. So on the left side of the screen, you see a patient that is amyloid negative and doesn't really have any tau either. In the middle, you see someone who's positive for amyloid, and you see lots of areas, those islands of red and yellow. On the bottom, you don't see much tau, but on the right side, this is a patient that has a positive PET for amyloid, lots of areas of red and yellow, and a positive PET scan for tau. You can see that area of redness right here on the right side of the brain. So now I'm just going to jump in a little bit to talk about current state treatments, where we have been and where we're going. But before I do, I just want to pause and make sure, are there any questions about what I've talked about thus far?
Don't have any in the Q&A right now, okay. So I think you're okay.
Okay, great. So if you are diagnosed with Alzheimer's, kind of the first moves that a neurologist would make is to start prescribing oral medication, because it's easy to take and has a fairly decent side effect profile. And so Aricept was the first approved Alzheimer's treatment that came out in 1996. This is an anti-cholinesterase, and basically this is not a really targeted therapy for Alzheimer's. So this doesn't do anything specific to tau, doesn't do anything specific to the amyloid. The idea is to increase the neurotransmitters, the chemical signaling that occur in your brain. It's just meant to increase everything. Similarly, Exelon, which is rivastigmine, was approved a few years later, and Namenda in 2003. All these are kind of, I would say, non-specific treatments for Alzheimer's, but they definitely have served as a bedrock for nearly 20 years before we had anything targeted. A lot of these treatments are started low dose, and you try to increase the dose as high as you can until you hit side effects. So for instance, because it's increasing acetylcholine in the brain, you get these side effects of like anorexia, loss of appetite, nausea, dry mouth, for instance. So, though many people can tolerate, there are definitely folks that can tolerate high dose or just suffer a lot of side effects. As I said, for 20 years, this is all we had. But a major breakthrough started occurring last few years, and this was really trying to have targeted therapies to the abnormal proteins in the brain. So lecanemab, for instance, is an antibody that was designed to attach itself to fibrils that form amyloid. Okay, So if you think of amyloid as a brick wall, where we're trying to attach to the bricks before they really get aggregated into the wall. So as these amyloid fibrils float, the Leqembi antibody attaches it, and it creates sort of an inflammatory reaction to allow other cells, like support cells around the brain called microglia, to come and absorb it and then take it out of the brain. So it increases the clearance of amyloid, and it does it actually very impressively. So Leqembi really reduces the amount of amyloid you see in patients with Alzheimer's. And so you remove the amyloid, but was there any clinical benefit? And they did show a slowing down of dementia. So in these clinical trials, there are different scales or tools that we use to categorize someone's level of dementia. We ask patients, what they've done the last couple of weeks. We ask their caregiver, are they doing activities? Are they taking care of themselves? Are they cleaning themselves? Are they engaging in hobbies? So we take information from the patient and we take information from their family caregiver, and we utilize both to make a determination of the current level of cognition and function. So, so in the top box, in box A, this is a very common scale called a CDR. This is a clinical dementia rating score, and you can see two curves here. And this is a plot in the blue line of people who were given placebo over 18 months in this trial. So everyone's starting at a baseline, and as their dementia increases, their score goes down. Okay, so the placebo group in blue line had continued progression of their dementia. You can see that the Leqembi group, after 3 months, they started having a slowing down of the progression of dementia. It wasn't a reversal. It didn't go back to baseline, which is at the 0, but you can see a bending of the curve, and that effect continued, and at 18 months, you still saw a separation of the curves. This correlated with what I talked about, was reducing the burden of amyloid on PET scan. So as you can see, the people who were given amyloid, placebo, had really no difference in their level of amyloid over 18 months. But in the people treated with Leqembi, and this is an IV infusion every 2 weeks, you saw almost a 55% reduction in the total amyloid in the brain. So as a proof of concept, we've always wondered for many years, is amyloid in the brain merely a signal or proxy marker of disease, or is it really a intrinsic factor in the progression of disease? And this study, this drug would support the fact that, well, if I target amyloid and I reduce the amyloid, I'm seeing some improvement in cognition. So this is what we would call really disease-modifying therapy, a targeted disease-modifying therapy, which is different than what I talked about earlier with those pills of Aricept, Namenda, or Exelon. I'm going to pause right here just to see if anyone has any questions before I go further, because I think I've thrown a lot at you guys.
Yeah, so we did have a hand go up. Please know, guys, we do have the microphones turned off, but you can put your questions in the Q&A, and I'm happy to read them out to him. Okay. So if you do have any questions, feel free to do that.
Okay, so while they type that out, then I'm just going to continue then. Okay, so there's no such thing as a free lunch, and so if we see some benefit, what are the side effects? And I think one of the more well-known side effects is a potential for some brain swelling and brain bleeding. And to be honest, I think this side effect, or is, though severe or could be significant, I think has been a little bit overblown. So in this trial, nearly 1,800 people, they were followed very closely for any sign of swelling or bleeding, and we call that ARIA, which is amyloid related imaging abnormality. And we talk about swelling, which is edema, and we also look at hemorrhage, which can be microscopic hemorrhage or real bleeding. I will say most of those events were asymptomatic. The people didn't really know anything, but there was a about twice the amount of risk of swelling in the brain in the Leqembi group versus the placebo group. So it's just interesting to note, like even in placebo, that 7.7% of people still had some asymptomatic brain swelling here and there on MRIs, which probably
Okay,
would
we
not
have
have.
two questions when you're
Okay.
ready.
Let me just finish this slide, then we'll pause. And
Yeah.
then with microhemorrhaging, there was a very big difference. You saw nearly 13% of people had some element of either micro or macro hemorrhaging versus only 1.7% of placebo. But most of this hemorrhaging was microscopic. Again, didn't really result in symptoms. If you talk about a microhemorrhage, something significant, it was only 5 people out of 989, so 0.6% versus one person. So I think when a neurologist does recommend, these therapies, I think it's a fair discussion to talk about someone's risk. And if you have ApoE mutations, it seems that definitely increases the risk of these events. And I think some practices or some centers are very careful to screen out people with ApoE4 mutations. But if you don't have an ApoE4 mutation, I think the overall risk of this resulting in something significant is actually quite low. So there is a side effect. It's there, but I think it needs to be put into a context of absolute numbers. So I'll just pause right here and see what questions you may have.
Perfect. So our first question, is there nothing yet available for improvement of symptoms?
Well, so if you talk about symptoms in general, nothing sustained. I think, when people first get started on Aricept, for the first 3 months, we may see a bump in their function. Sometimes, to be honest, like we see better behavior. Sometimes people are less calm, less agitated, a little bit more willing to follow their caregivers. So you may see a level improvement on the function with like doing chores or self-care or things like that. That little bump occurs for about 3 months, and then after that, you see them kind of go back down. So it's a slight bump, but it's not a sustained bump. But something that can actually reverse dementia and get people to their baseline, there's nothing close to that just yet.
Okay. And the next two kind of combine together. Lequembia, is it recommended for moderate to severe Alzheimer's or other dementias? And then the second part was, is it limited to early stage?
Yeah, at this point, Leqembi is really limited to early disease, either someone in the mild cognitive impairment stage, MCI, or early Alzheimer's. So that determination is really made by the neurologist involved, and usually they base that on something called the mini mental status exam, the MMSE, to kind of base people. But yeah, it was really meant for early disease at this stage. And I think, going to a point, I think it's with dementia, it's important to catch it early and start treatment early before you lose too much function, because as of yet, there's really nothing that can reverse. So what's lost is lost. And so the hope is that if we can catch disease early and treat it, then we can actually see sustained results.
Okay. And then the next one is, what are the results beyond 18 months of taking Lequembia?
Yeah, for I think the Eisai is a company, and they did release some longer term data. I think now it's out to 3 years. They're seeing a sustained reduction in the amyloid in the brain based on PET imaging, so that's good. And they're seeing so at this stage, I must say that there's no placebo-controlled group that went out to 3 years. So there's no active comparator. But what they can say is, compared to historical controls, that they feel the people that are on treatment still have less progression of dementia. I think what Eisai is also working on is that obviously, people are not very enthused to go to an infusion center every 2 weeks to get this, and they're working on subcutaneous injection formulations, and it's now in a research stage. So I think what they're going to try to move for in the next year or two is get approval for this to be injected, at home or by a caregiver, so you don't have to go into an infusion center. Secondly, what Eisai is also working on, I'll talk a little bit about this, is they're doing a trial where they're combining Leqembi, which is targeting amyloid, and they're combining it with something targeted against tau. So an anti-tau, anti-amyloid together. And the hope is by doing kind of like a multimodality therapy that they can even see more benefit.
Okay. Our next question, are researchers working on regrowing brain cells?
Yes, but unfortunately, you know, we really haven't been able to make anything that, because growing brain cells in a petri dish is technically possible, but growing it inside a brain and regrowing the synapses and connections to make it really functional, we're nowhere close to doing that.
Gotcha. I actually heard from another physician last Friday that I thought was an interesting way to explain it for who's eligible for it,
Yeah.
is that the taus and amyloids are like a light, fluffy snow that you can scrape off. And so if they're still able to do that, then they're in the right stage to use the medication, which I thought was an interesting way to
Thanks
describe
for
it.
yeah, definitely.
All right. Well, no more questions right now,
Okay.
so you're good to go.
So thank you. Those are great questions. Um, so Leqembi came out, and then shortly thereafter, Eli Lilly announced the results of their Trailblazer trial. This is with an antibody, similarly anti-amyloid called donanemab. It's now being sold as Kisunla. Similarly, they had a trial with about 1,700 participants, and they were able to show that there was a slowing down of dementia in the people treated with donanemab. For this study, they didn't use the CDR. They used a different cognitive scale called IADRS. But you can see that over a year and a half, there was a separation of the dementia curves. Similarly, as I said, there is no free lunch, and just as with Leqembi, there is a small risk of ARIA, hemorrhaging, or edema, which was seen about 24% of the donanemab group versus 2.1 of placebo. And it's very hard to compare the two trials because there was kind of different enrollment criteria, and in some ways, the donanemab trial was slightly more advanced disease. I know people try to crunch numbers like which one is safer, which one has a higher level of bleeding, and I think it's hard to make a comparison because it's really apples and oranges in that respect. Now, currently, there are other anti-amyloid treatments in development, and I just want to also preface this that not every anti-amyloid treatment has been effective. And a couple years before lecanemab came out, Biogen had developed a drug called ducanumab, and it was controversially approved by the FDA, despite a lot of criticisms by experts that are actually in the FDA. It was approved based on some very creative mathematics and showing a benefit, but this was offset by the bleeding and edema in the brain. And so it was approved by FDA. Medicare never agreed to pay for it, so there was never a market for it. And so Biogen actually has stopped making it and stopped marketing it. So it's one of these kind of ghost drugs that are now approved. I will say there are two different anti-amyloid treatments kind of in phase 3 development right now. Eli Lilly has a compound, and then Roche has another drug called trontinemab, and actually Sana Research is going to be enrolling for that trial. That's going to be starting probably like mid to late summer. It's interesting that Roche had developed a different anti-amyloid treatment called, and I'm not going to probably butcher this one, but donanemab. And this one didn't cross the blood-brain barrier that well, so they didn't get good penetration, and they were unable to show any significant clinical benefits. So they stopped that trial early. Trontinemab, their new compound, is reformulated to have about 20 times the penetration into the brain. So they are more confident that this one should be able to show some significant reduction in the amyloid plaque, and hopefully they can show clinical benefit as well. So I've talked about the anti-amyloids, and we will turn our attention a little bit to the anti-tau, because amyloid is, again, that starchy stuff that accumulates outside the brain cell, but inside the brain cell you have these tangles that are made of tau. So there have been a couple of drugs that have been targeting to reduce tau levels. One of them had some initial enthusiasm. It is a interesting drug, kind of derived from something called methylene blue, which when you ingest it, it actually makes your urine blue. So it's very hard to do in a placebo-controlled trial because you kind of know if you're taking the drug or not. The Tau RX was developing this. They had some positive data at 12 months, but when they continued the lucidity trials at 24 months, it failed to meet any endpoints. So the drug is kind of in this suspended state of development right now. Next one, as I mentioned earlier, Eisai, the one who developed lecanemab or Leqembi, is developing an anti-tau drug, and they're going to use it in combination with lecanemab in an upcoming phase 3 study. So I think they're finishing out their phase 2, which is an earlier stage of trial, and then hopefully they can launch a larger trial in a year or two. What is interesting is there's another drug out there. Oh, I'll actually pause. I think there are 2 questions here.
There are.
Yeah.
So the first one is, are there trials for people with moderate to severe Alzheimer's?
I don't think so. I think the companies are now really focusing on early stage. The problem is, with moderate, when it's going to be very hard for them to show any benefit. And also, once people get into that moderate level, it's actually very hard to test people because a lot of them start losing their speech skills or they're unable to maintain focus. So they're unable to participate in like a 2-hour assessment. I mean, we've had patients on that level where, we're trying to do very simple things of like using a laptop to test the reflexes or to follow their attention, and they just can't. So it becomes very hard for us from a testing side just to adequately test these people using these scales. So that's one of the difficulties logistically.
Yeah. And then our next question, are you aware of the results of the TB006 from True Binding that is available as an expanded access program medication showing reversal of decline and improvement that persists while on treatment? Savannah Bio is working to replace the ABNL microglial calls to treat Alzheimer's.
No, I don't know that one. If you could put a link in the chat, I'm happy to look into it, but I don't know that one.
All right.
Okay. All right, so moving along, there's an oral compound being developed by Annovis, and actually our site is going to participate in enrolling for this one. So, I focus on amyloid and tau. Those are the 2 neurotoxins, the bad proteins that we see in Alzheimer's. And there's also a neurotoxic protein that causes Parkinson's disease, Lewy body dementia, and that's called alpha-synuclein. And so when you look at a Parkinson's disease patient and you stain their cells, you'll see these aggregates called Lewy bodies. So butanatab is an interesting compound that was initially being developed by the NIH, and it blocks the protein formation of both amyloid, tau, and alpha-synuclein. So it's a very interesting compound that it can target multiple neurotoxic proteins at the same time. In phase 2 trials, they were able to show some benefit in Alzheimer's patients as well as in a separate trial with Parkinson's patients. So the company is now launching a larger study to test it in Alzheimer's population, and I think they're going to also launch a phase 3 study in Parkinson's patients as well. This is some data that they showed from their phase 2 trial in the ADAS COG11 test. The bigger the score difference, the better. So it's a little bit different than the other tests I showed you, but sorry about that. So in the placebo group, there wasn't very much of a difference from baseline. And then you saw better improvement in a dose responsive mechanism from the 7.5 to 15 up to 30. The phase 3 study is going to test a 30 milligram once a day dose by mouth compared to a placebo for 18 months in people with mild Alzheimer's. So we're going to be very interested to see if this can show sustained clinical benefit. This is a very busy slide, which intentionally is meant to show you how many different studies are in development. So this is a circle that shows all the different clinical drugs in trial from phase 1, phase 2 to phase 3. What I've been focusing on is talk about these disease-modifying biologic agents that are targeting amyloid or tau, but certainly there are other drugs, as I guess one of the participants mentioned, that are trying to target different aspects of the disease. So again, this overall, I like seeing the slide. I want to see thousands of drugs in development. So I think this should give caregivers and families of people with Alzheimer's hope that there are drugs, a lot of drugs in development. So, hopefully if I was to do this talk in 5 to 10 years, I would have lots of different drugs and drug classes to talk about. I know we're reaching in a time, so I just want to talk about biomarkers for a little bit, because whereas targeting tau thus far hasn't really been effective, tau has become important as a marker of disease. And I think this is where the diagnosis of Alzheimer's is really being revolutionized right now. So when you look at tau, it does seem that sometimes up to 15 years before there's actually any symptoms of Alzheimer's, you can actually detect some elevations of tau, first in the CSF or the central cerebral spinal fluid or in the bloodstream. And so as tau accumulates in the brain, you'll see it spill into the CSF fluid and then eventually into the bloodstream. And so several different companies have now developed phosphorylated tau tests. These are just blood tests that can look for tau. And they're different. There's like tau 217, tau 247, but it looks like p-tau 217 is going to be the most accurate and probably the one that will be most widely used. And this is an interesting study that looked at, well, how accurate are doctors diagnosing Alzheimer's, and would blood testing be more or less accurate than that? So these are 1,200 patients that are undergoing cognitive evaluation for dementia symptoms. And the gold standard in this cohort was that these people all had lumbar punctures. They were taking out some CSF fluid and analyzed to see if we can find either amyloid or tau. Because if you have amyloid or tau in the CSF, you have Alzheimer's. And so that's the gold standard of the test. And if you look at, who made the diagnosis of Alzheimer's, a dementia specialist made this accurate diagnosis in 73% of the people, compared to 91% when you use the biomarkers of p-tau and a biomarker for amyloid, beta 4240. So nearly 20% more accurate when compared to dementia specialists. And when you looked at primary care doctors, they made the diagnosis 61% versus 91% again in the biomarkers. So the biomarkers are more accurate than a physician evaluation, testing, and whatnot. So, so based on this, the Alzheimer's Foundation last year has released a new paradigm of how you make the diagnosis of Alzheimer's. The diagnosis now can be made based on biomarkers, either biomarkers of PET scan, like imaging testing, or serum testing. And so they've made different stages. And I just want to highlight that if someone has an abnormal, PET scan, that they have the biological diagnosis of Alzheimer's, even if they have no symptoms. So this is important. So someone who's cognitively intact, still intelligent, still working, if they have amyloid or tau, either in PET or in blood testing, we can say, actually, you have Alzheimer's now. And I think this is the opportunity that person could be enrolled in a trial, and maybe we can find a drug that stops the progression of disease before you actually have symptoms. And I think this is where we're gonna make the most impact of this disease. And I think this paradigm is actually challenging. It's a new, I mean, a lot of neurologists are still kind of struggling how to incorporate this. I think one of the challenges with this biomarker testing is that although Medicare has assigned a number for p-tau testing, there has not yet been a Medicare reimbursement plan for this. So you could get a p-tau test, but you're going to have to pay a couple $100 out of pocket. And there are several different labs that can do it. And I think hopefully by the end of this year that Medicare will start reimbursing testing for p-tau. And if so, I think this will revolutionize, the testing and diagnosis in primary care, because that's going to make the biggest impact. Because I think it's really hard, even in this area, to make an appointment with a neurologist. So if you have a family member who you're kind of worried about, like, gosh, I think they're starting to lose their memory a little bit, they're asking a lot of repetitive questions, or they got lost one time for no reason, the primary care doctor in the future will be able to send them to LabCorp, Quest, or something, get a p-tau test, and you can make the diagnosis of Alzheimer's, and hopefully then start treatment, start something sooner than waiting for this to progress for months or years. I'm going to pause right here because I think there are 3 questions in the chat now.
There are. So the first one, can an individual ask their doctor to request the blood test for the biomarkers?
Yes, like again, you can get this tested. Quest has a commercial assay. LabCorp, C2N is a testing company that branched out of Washington University. They can do it. Unfortunately, again, it's going to be out of pocket. It's generally not going to be covered by private insurance, and it's not covered by Medicare this yet. And I should preface this that you really should only test for this at this stage if you actually have symptoms that are concerning. So though this is an exciting test, it's not ready for anyone anytime in their 20s, for instance, to test, right? I wouldn't test someone unless they had something concerning as a potential symptom.
Perfect. And the next question, when asked when we would have a cure, my person with dementia's doctor said there would not be a cure in our lifetime. The doctor went on to say, maybe in our grandchildren's lifetime. I'm 44. What's your opinion?
I'm hopeful, I'm optimistic. I think it's gonna kind of like how we attacked HIV with like a cocktail of targeting disease at multiple steps. I think probably we're gonna see the same approach. And that may be a combination of anti-amyloid, anti-tau, maybe anti-alpha-synuclein. So I'm hopeful that, hopefully when I hit elderly age and, when I retire in 20, 30 years, that there'll be a lot of options I can treat it. So I think the revolution going on right now is both the diagnosis and the treatment. And I think we're going to see the fruit coming out in the next 5 to 10 years from that.
Yeah, and you hit a very good point. Getting a neurologist is about 4 to 6 months out in the area. And I talked to a few neurologists at a conference Friday, and the one thing they requested, so for families listening that are trying to get into a neurologist, if you can get the MRI done before the appointment, get a basic screening of CBC, your CMP, your TSH, your vitamin D, and your vitamin B12.
Yeah.
Before you get your appointment, that is going to be helpful in moving the process along, and also getting your neurocognitive testing done, because you can get that at different locations, not just at the neurologist you go to. So that's just their insight. I'm going to try and put something together so that we have it on the website to have all that information for you guys, but that will help you get through that process a little bit faster and keep you busy while you're waiting for the appointment as well.
That's great advice, Melissa. Yeah, I mean, even though we live in a major metropolitan area with tons of hospitals and specialists, like there are just not enough neurologists in this country. And especially as I talked about this, this huge wave of people entering, advanced age, and with that, so many more people with dementia. A lot of the diagnostic burden is really going to be with primary care, and whatever you can do proactively while you wait for a neuro eval with either imaging or blood testing is important. And if you can get, a p-tau test, if that is positive, I think that clinches diagnosis. If it's negative, you still could have Alzheimer's. I'm not saying that's impossible, but it does make it a lot less likely. And you should think about other causes. Okay, I'm just gonna wrap things up a little bit, and then I can pause again for any kind of questions. But I just want to touch on diversity a little bit. I know, like in this new political environment, DEI is a bad term, but we do have a diversity problem in Alzheimer's trials. Minority populations such as the Black community, Hispanic community are more likely to have Alzheimer's than white Americans. But if you look at trials, 80 to 90% of participants are Caucasians. So the clinical trial population does not reflect the general population. And There are cultural problems to this. African Americans traditionally, due to Tuskegee incidents, have a higher level of mistrust in the medical system, and therefore have a higher level of mistrust of researching. And so that's a huge barrier that both the clinical research sites and pharmaceutical companies are trying to work on and try to solve. But interesting, there may be some biological differences because some of the trials to enter require a positive amyloid test or a positive p-tau test. And there does seem to be some data that the levels of amyloid in a black population may tend to show up a little later in disease compared to the Caucasian populations. So some of the black patients may be screened out inadvertently because they're not meeting the entry criteria, and that may be due to some differences in the biology. So that's kind of an interesting problem. But again, I can say as a researcher, I'm committed to really serving the underserved community, finding minority populations that want to participate in trials so that our data is more reflective and more useful to the real world. And I talked about this, and we'll wrap up. But beyond Alzheimer's, treating the dementia, especially in the moderate severe stages, then you start getting to agitation or behavioral problems. There was a new drug approved recently called Rexulti to reduce agitation symptoms in patients with Alzheimer's disease. And on that, there are 6 different studies looking at different compounds to reduce agitation because by and large, we want people to age in place, but a lot of that is a burden on the caregiver. And if the caregiver is dealing with a lot of agitation, that's more likely to push someone into assisted living or memory care. So I think caregivers need more tools to help them and help reduce agitation symptoms associated with progressive Alzheimer's. So I'm just going to stop right there, and I'll stop sharing, and then hopefully this has spurred some questions from the group, and we can take some time for Q&A.
All right, so here's our next one for Victoria. What do you know about proclivity AD?
Proclivity, I believe proclivity AD is a testing assay that combines p-tau and amyloid 4240, and they create like a risk score. I think current state, that risk score just gives you like a high or low risk for Alzheimer's, but they don't individually report out the levels of p-tau or the amyloid 4240.
Okay. And then our next question, are there certain foods to stay away from that will prevent the onset of dementia or Alzheimer's?
Yeah, I mean, I think alcohol is definitely a big contributor to dementia. And, from a cardiology side, one could argue that alcohol does have some benefit cardiovascularly, but I don't think there's any level of alcohol that is shown to improve cognition. And I think, reducing alcohol consumption, and especially as you age, it's important to kind of preserving as many brain cells as you can. Beyond that, generally, avoiding processed foods is important, and really eating kind of a Mediterranean or fresh food diet, high in fiber, high in vegetables and fruit, I think is the most sensible thing. Other lifestyle things to focus on is exercise. It's good for your heart, it's good for your brain. Being sedentary is no good. Getting good sleep is important as well, and I know as you get older, sleep becomes more fragmented, and that's a struggle into itself, but really trying to maintain adequate rest. And then the last lifestyle thing to focus on is staying engaged, working with people, volunteering, being active in your church or temple. I think that's all important. And I do see, especially in guys as they age, men tend to withdraw more. And, I've seen a lot of men just watching, CNN or Fox News all day long, or just surfing the web and kind of withdrawing. Women, to a lesser extent, and I think staying socially engaged is good for your brain, good to be active mentally and physically.
So there was a study in AARP. I love sharing the statistics because it kind of opens people's eyes. Increased isolation over a long period of time is the equivalent to smoking 15 cigarettes a day.
Wow.
That's how much it tears up your body. So just to kind of give you guys perspective, to answer that diet question too, the MIND diet is the big one they're picking on because it combines the heart healthy and the Mediterranean diet together, and they say that's the best one for dementia right now, I guess. So one other question: are you still accepting study patients in your Arlington location?
Yes, we are. So we are now pre-screening for the Anavus study, the butanetap study. You can call or email me. I believe, Melissa, I think our contact information was circulated somehow.
I believe so, but we can make sure that it's included when we put the webinar out. We can do that.
Yeah. I will say for all studies that participants must have a family member or caregiver that will come to all the research visits, because I said the cognitive testing is dependent on the answers from the participant as well as their caregiver. So, and that's another problem that, socially isolated people who live by themselves or don't have a social network, and these people cannot go and get into studies.
Yeah. Everyone says eat well and exercise, but why? Does exercise increase your blood flow, and does that act like a filter or something? Why does that combination work?
Um, we always have theories on why it works. I think we just know it does work, and then I think we can spend more time in theories. Of course, it does increase your blood flow, but I think there are a multitude of other factors, right? Like you're releasing probably healthy cytokines or healthy proteins in the brain that regenerate things, that reduce inflammation, oxidative stress, this and that, So, I mean, honestly, in medicine, like we don't we don't know why things work as much as we know what works. And I think it's very clear from the data that exercise is good for the heart, it's good for the brain. So
Perfect. When should we expect updates on research and medication, and how often? So I know if something big comes out, we usually find a doctor to talk about it because we did that with the last two.
yeah.
But my goal is annually to have this,
Yeah.
regardless of that information. But I mean, he might have a better idea of when things are going to pop up.
Yeah, I mean, generally at the pace of things, I think they're made, with all the drug development, at least once a year, I think you're going to start seeing either a major trial declaring success or failure. Um, the announcements tend to cluster around major conferences. So, for instance, the Alzheimer's Association conference is coming up at the end of April, and there's another conference in the fall that they tend to announce results. So, if you tend to look at the spring and fall, it'd probably be the most amount of announcements twice a year.
And then I had a question for you. This came up in the support group today. What are your thoughts, since you brought up the new behavior medication that they're using, your thoughts on CBD gummies?
I don't know if they have that much data on CBD just yet. I mean, I know it's very common and popular. It's hard to say. Everyone's kind of individual with that, and and are we talking about CBD? Are we talking about actual THC? You know,
Yeah.
And so I would say, like, I'm sure there are people that benefit from the THC, and to a lesser extent CBD, but we just don't have that much research out there. It's interesting. This has come up both in like our multiple sclerosis studies and some others that
Mhm.
the drug companies are allowing people to participate in trials even if they are taking THC or smoking marijuana, as long as it's kind of a stable dose and something that we don't think is like at a level of abuse. So a lot of the treatments are being used on top of CBD or THC, but the exact benefit of that, it's unclear. And I don't think any of those THC companies are going to sponsor like a $50 million study to, find out that yet. So.
I'm happy to help if you want to work on getting a research study for that, because I get lots of questions about it.
Oh, okay. Yeah. Maybe we'll do something on the side.
Yeah, I would love to. There's not any other questions. I want to share my screen real quick.
Oh, there's a heart.
There is a heart. Someone loved it. You did a great job with your presentation. I just want to thank you all for being here. Let you know that upcoming events you can see on our website at insightmcc.org/events. Next month, we're going to do a research study on frontal temporal lobe, and the month after that will be Lewy body. So we're going to make sure we get all three of these for us. We also have plenty of other presentations as well. So thank you for coming. And we will get this webinar up in about a week. And you can always reach out to me at any time if you have any questions. We do free consults, or, if you're dealing with a difficult behavior and you need some advice, let me know and I'm happy to answer those. So thank you again, Dr. Tran, for being here, and thank you all for being on.
Thank you so much. Thank you everyone for coming, and I wish you everyone the best. Thank you.